This episode is sponsored by the TTM Academy at Penn Medicine, an educational initiative to improve care for patients following cardiac arrest and other neurocritical care illnesses using targeted temperature management. Find out more at penttm.com. Hey podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and this is another episode of the Neurocritical Care Society podcast. In an age where nearly 25% of all ICH patients are on anticoagulation and antiplatelet agents, as neurointensivists, we frequently find ourselves on the forefront of the acute management of intracranial hemorrhage, withholding and reversing anticoagulation, and later on struggling with when to restart them. With the risk of arterial ischemic events after intracerebral hemorrhage being poorly characterized, have you ever wondered what the repercussions are of withholding anticoagulation? Are we predisposing our patients to a higher risk of ischemic stroke and myocardial infarction following ICH? And if so, when are they at the highest risk? Well, Santosh Murthy and colleagues attempted to answer that question in the recent work entitled Risk of Arterial Ischemic Events After Intracerebral Hemorrhage that was published in Stroke in November 2019. I hope you enjoy this episode.
Hello everyone, I am Sterling Shepard, Assistant Professor of Neurology in the section of Neurocritical Care at Rush University Medical Center. My guest for today's episode is Dr. Santosh Murthy, an Assistant Professor of Neurology and a Neurointensivist at Weill Cornell Medical College in New York City. We will be discussing his paper published in the journal Stroke titled Risk of Arterial Ischemic Events After Intracerebral Hemorrhage. Thank you, Santosh, for joining us on today's podcast.
Thank you very much for having me. It's a pleasure.
Okay, great. So let's dive right in. As intensivists, we know that patients with intracerebral hemorrhage often have both high mortality and morbidity rates. How did you become interested specifically in looking at the rate of arterial ischemic events? And can you also define for our audience which arterial ischemic events did you look at?
So that's a great question. You know, as you rightly pointed out, as intensivists, we see a lot of patients with intracerebral hemorrhage or ICH, and we are often worried with the acute set of events, hematoma expansion, but we don't normally get to care for these patients long term. So we often don't know what happens to them after they're discharged from the hospital. And when we reviewed some of the literature that was published, we found that pretty much most people saw that acute infections, particularly sepsis, were some of the more common reasons, but nobody really had a good sense of what the other conditions were. So that's really prompted us to dive deep into this subject. And so we wanted to specifically look at arterial ischemic events. In other words, arterial thrombotic events, which were acute ischemic stroke and acute myocardial infarction. And the reason we mainly wanted to look at these two in particular is because nearly a fourth of all patients with ICH end up being on antithrombotic medications. And as we all know, these medications are withheld in the acute setting of ICH. So we felt like, this was a very rational next step to see if withholding these medications in the acute period of ICH resulted in a short-term and a long-term increase in the risk of such arterial thrombotic events.
Okay. And can you tell me about your study design? Was this a prospective or a retrospective study?
So this was a retrospective cohort study. We used data from the Medicare database, which is a nationally available database which can be obtained upon request. So this is actually collected by the Center for Medicare and Medicare Services, or the CMS as we know them. And what they do is they give you a 5% sample of the data set for analysis upon request. And so using this particular data set, we got inpatient and outpatient hospitalization records of a 5% sample of Medicare patients, and we set about doing this retrospective cohort study. For this particular study, what we did is we actually excluded patients who had a diagnosis of stroke or an MI at the time of baseline inclusion. And we also excluded patients who had a stroke or MI when the ICH hospitalization was diagnosed. The reason we did that is because, this is an administrative data set. So it's not entirely obvious whether the stroke and the MI happened first or the ICH happened first, if it's all taken during the same hospitalization. And so sometimes you can have an ICH as a complication of one of the procedures that's done for the acute stroke or the acute MI. As a result, we wanted to keep the data set clean, so we excluded all these patients.
Okay. And since you used the Medicare database, all of your patients were above the age of 65?
That's correct. Typically, as you know, CMS, patients get into the CMS data set as they're over the age of 65, but in order to allow entry into the database and allow for all the comorbidities to be adequately included, we only considered patients over the age of 66 so that we had this data available.
Okay. And what specifically were the primary and secondary outcomes that you looked at in this study?
Our primary outcome was, as we discussed, an arterial ischemic event, and that was defined as a composite of either acute ischemic stroke or myocardial infarction, MI. And for secondary outcomes, we looked specifically at just ischemic stroke alone and myocardial infarction alone.
Okay. And were there any other cardiovascular risk factors and comorbidities that you analyzed or looked at?
Yeah, so as part of the baseline covariates, we obviously got data on the demographics, age, sex, race. Mm-hmm. We also got information on some of the comorbidities like hypertension, hyperlipidemia, cardiovascular risk factors like heart failure, atrial fibrillation, valvular heart disease. And as we have done previously in most of the administrative analyses, what we do is we also calculate a composite comorbidity score called the Charleston's Comorbidity Index. And so that is an additional score that we also looked into for this particular study.
Okay, so let's dive right into the results. What was the incidence of ICH in the study population?
So we really didn't look into the incidence of ICH as such.
Okay.
We only specifically looked at the rate of ICH. And overall, I think we had about 5,900, close to 6,000 cases of ICH in the entire study. The overall study cohort included about 1.8 million Medicare beneficiaries, and this was the number that we found.
Okay. And what percentage of those patients were diagnosed with these arterial ischemic events, and were there any identifying characteristics?
In terms of the patients who ended up with an ICH and an arterial thrombotic event, we found that mostly these patients, as expectedly, were older in age. They were 79 years. That was the mean age compared to 73 in the group without ICH. These patients were predominantly more likely to have vascular comorbidities like hypertension, diabetes, congestive heart failure, atrial fibrillation, and valvular heart disease. So overall, what we found was that cumulative incidence rate was about 5.5% in patients who had an ICH in terms of arterial ischemic events.
Okay. And did you find that there was any temporal relationship of risk of one of these arterial ischemic events to the initial ICH?
So that's a good question. So as I said, we ended up excluding patients who had a stroke or an MI either at baseline or during the index hospitalization for ICH. So that was our way of making sure there was no temporal relationship between the stroke and MI leading on to ICH. And so that was our way of making sure we sort of had a clean data set and, sort of a clean slate to begin with, in which case all patients do not have any stroke or MI at baseline.
With continuously updated content on topics ranging from acute ischemic stroke to clinical evaluation of coma and brain death, prognostic assessment, and traumatic spinal cord injury, Neurocritical Care On Call is the only product of its kind to offer content exclusively dedicated to the practice of neurocritical care. This interactive, subscription-based website features tables and figures, videos, author insights, and sections specific to nursing, pharmacists, and APPs. To learn more about subscribing to Neurocritical Care On Call, visit www.neurocriticalcare.org/on-call. Use promo code PODCAST for an extra 10% off your subscription.
Okay. How about, you mentioned that you looked at patients with MI only and patients with ICH only rather than the composite. How about patients with MI only after ICH? What did you find there?
So that was actually an interesting finding. In the overall primary analysis, we found that having an ICH was associated independently with a short-term heightened risk of arterial ischemic events, and that was when we took stroke and MI together. We found that this risk was significantly elevated within the first 6 months, but mostly within the first month, and slowly the risk started coming down. But even at the end of 6 months, it was pretty significantly elevated at 2.5-fold. When we looked at myocardial infarction separately, we actually found that there wasn't really an association between stroke and MI, regardless of the time period that we looked at. Mm-hmm. And we thought that was a very interesting phenomenon because we did find a significant association between ICH and acute ischemic stroke, and that was very similar to what we had seen in the primary analysis.
Okay. So why do you think that was? Like, why do you think you did not find a relationship between MI and ICH?
I think that's a very interesting question and a very intriguing one, actually. Something that we were very puzzled by. Now, one of the main limitations of the administrative data sets is that we don't really have data on antithrombotic medications because we used the Part A, Part B Medicare data set. So obviously that was one concern that we had. Now, it's possible that patients with atrial fibrillation are generally not restarted on anticoagulant medications, and there is data from the Scandinavian registry to show that less than 25-30% of patients are actually restarted on anticoagulants. Whereas when it comes to antiplatelet therapy, people are a little more aggressive in terms of restarting them. So it's possible that perhaps in this data set, antiplatelet medications were restarted more aggressively than anticoagulants. And based on data from randomized clinical trials in cardiology, we know that having antiplatelet therapy on board is preventive for myocardial infarction. So that could be one particular reason. Alternatively, it's also possible that maybe a bleed in the brain sets off inflammatory process, which is exclusively contained within the central nervous system. That probably results in acute ischemic strokes and not really a systemic one that would result in myocardial infarction.
Okay. So you mentioned earlier, we just mentioned, that patients with atrial fibrillation and ICH and, who may also need anticoagulation for other reasons are not typically restarted on their anticoagulation. Do you think this is the primary reason that these patients seem to have an increased rate after ICH overall, or did you somehow exclude those patients?
Absolutely. That was definitely another question that crossed our mind. That, is atrial fibrillation, valvular heart disease, and antithrombotic therapy playing a very big role in this? It probably still is, but when we did our literature review initially, we found that even among patients with atrial fibrillation, for a CHA2DS2-VASc score of about 2, where you would expect an annual stroke rate of about 2 to 3%, the annual reported stroke rate in patients with ICH and AFib was as high as 10 to 11%. So clearly these patients had an increased inherent risk of, stroke and MI. And so that's what prompted us to look into this. And so we definitely did look into this more seriously as sensitivity analyses, where we excluded patients with AFib and with valvular heart disease. And regardless of whether these indications were present or not, we found that the results were very similar to the primary analysis, where ICH was independently associated with a short-term risk of ischemic stroke.
Since you were looking at ICD-9 codes, do you think this somehow influenced the results of the study?
Absolutely. Errors in misclassification have been reported in the past, but also the algorithms that we use in the identification of both the exposure and the outcomes have been validated in previous studies. And so we knew that they have very high sensitivity and specificity. And so whatever error would actually shift the results towards the null. So only that would strengthen our the results of our analysis. But definitely errors are possible. I think it's also possible that, particularly for future hospitalizations after an ICH, patients may have been miscoded as stroke and not really as ICH. And that was another concern that we had. But again, as I said, sensitivity and specificity of these particular codes are pretty high. So that probably wasn't as much of an issue.
Okay. And finally, what would you like us as neurointensivists who take care of patients with ICH to take home from your study?
I think, to be very honest with you, these results at best are hypothesis generating because, they obviously have their fair share of limitations. I think the very next logical step would be to do a more robust prospective cohort study where we have data on a lot of important variables such as vascular comorbidities and antithrombotic use and their resumption. And once we have these data and if these results are replicated, then I think we ought to very seriously think about putting patients on antithrombotic therapy after ICH, which sounds very counterintuitive compared to what we do. But before we get there, before we make any practice-changing algorithms or guidelines, I think the next step would be to come up with a randomized clinical trial to answer this question if these results are replicated.
Okay, great. Thank you, Santosh, for joining us on today's podcast and taking the time out of your busy schedule to discuss your paper with us.
Thank you very much for having me.
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Romani Ballou, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zammit. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.